Hello, everyone. My name is Dr. Ammar Kheir. I'm a consultant gastroenterologist at the Cleveland Clinic, Abu Dhabi. I have two guests for another episode today. So I have Dr. Sara El Ouali, one of our leading inflammatory bowel disease specialists, and I also have Dr. Abdullah Shatnawei, another leader in the space of nutrition of gastrointestinal diseases. So today's episode is how endoscopy diagnose patients. And before we start, we'll start by asking Sarah, what is exactly endoscopy?
Thank you, Ammar. So basically, endoscopy is really the fact that we're able to use this equipment, it's machines, with tubes. At the end of these tubes, we have cameras, and these cameras essentially can help us diagnose diseases, right? And so, for example, there are different types of endoscopies. There's the classic endoscopy, which we put through the mouth, and essentially it can allow us to see the esophagus, the stomach, and the beginning of the small bowel that we call the duodenum. Yeah. There are other types of endoscopies. There's a colonoscopy as well, which is another equipment that we put through the anus, and that actually helps us to assess the colon. And there are actually a lot of other types of endoscopies as well.
Thank you. So another types of endoscopy also is capsule endoscopy. It's a very popular question that we get from patients. So can you explain more on that?
Absolutely. I think this is a very popular question, and it's actually a very exciting tool as well. So a capsule endoscopy is actually a capsule that you swallow. It's just like a medication, like a pill, essentially. But it has a camera inside of it. And so it takes a lot of pictures, almost like a video. And so when the patient swallows it, essentially it takes pictures of course, quickly the esophagus, the stomach, but we're mainly interested in the small bowel. So really the point of a capsule endoscopy is to take pictures of the small bowel. Why is that? Well, the problem is our usual endoscopies cannot really reach the small bowel very well. The small bowel is very long, so the capsule really just takes pictures of your whole small bowel, and then we're able to diagnose things that we wouldn't have had access to otherwise.
Excellent. So I'll ask you, Abdullah. So Sarah mentioned upper endoscopy, which is to the audience, this is an endoscope that we use to examine the esophagus, the stomach, and the first part of the small bowel, as Sarah said. And then we have the colon that we examine the lower part of the gastrointestinal system, which is the colon. And then also we have the capsule endoscopy, where we can examine the mid part of the gastrointestinal system by swallowing a capsule that takes camera and takes photos. So why do we need these procedures, and what kind of, conditions or diagnosis can it help you to diagnose patients with who have symptoms, and what sort of patients should come to you?
Sure. Thank you, Ammar, and thank you for allowing us to talk about this important subject, in particular how to use endoscopy in diagnosing different gastrointestinal disorders. So patients can present to our clinic with different complaints. Always the question the physician and the patient ask is, what is the diagnosis? So it's very important for us as physicians to use different tools to reach to a diagnosis that help us determine the right treatment of the patient. So one of the tools in the field of gastroenterology, regardless of your specialty or area of expertise, is to use endoscopy, upper, lower, video capsule, and different, of course, advanced endoscopic procedures. So the scope is a tool that allow us to see the inside of the gastrointestinal tract, and if there's any area of suspicion, an abnormal area, we take a sample, a biopsy we call it, with a small, very small forceps. And also sometimes we take samples of a normal looking tissue to see if there's any microscopic problem or inflammation or reaction or disease going on. So basically we utilize these tools to get inside the gastrointestinal tract, visualize, and then take samples. This is basically for the diagnostic purposes.
Excellent. So you mentioned taking samples and taking what we call medically as a biopsy. And I think there's a general concern that we often hear from patients that they worry if we are taking a sample, especially if the condition was something to do with concern of a cancer, that this will spread. How would you reassure them, or how would you answer them?
Thank you so much. This is actually a valid concern for the patients. In the field of gastroenterology, most of the time we take biopsy from the lining, the inside of the gastrointestinal tract or the mucosa, and it's superficial to where you're looking at, and the small sample that we take is very unlikely to cause any problems with spread. Yes, there are other issues of concern such as bleeding or perforation, which is extremely unlikely to happen, but spread of the tumor in particular is not a big of a concern. However, in other tumors inside the body, when you have to stick a needle, go through a wall of the intestine, and then pull the needle out, when you create, theoretically speaking, a tract, yes, there is a valid concern. But this is a very small risk. Let me put it this way: it's an extremely small risk compared to the benefit that we get out of the biopsy that we take. I hope that answers.
Yeah. So I think we all generally feel nowadays that biopsy in general should not be a concern, that if we take it, that we are spreading a cancer.
Absolutely.
And now I think with the advancement of, as you said, these special situations where you're worried about the sheath and you're taking a deep tract biopsy, that now the equipment we have has evolved to the in terms of the safety and protection, that there's no spread of any cells or liquids or that anything within the body that would concern you, that this should cause what we call seeding or spread of the cancer outside of the area that you're taking
Correct.
from. Okay, so Sarah, what about Abdullah mentioned about the bleeding and the perforation, but I will ask you, as some of the patients have valid reasons to sometimes be worried about risks of having an endoscopy or a colonoscopy, whether it's an anesthetic complication, or is it bleeding or perforation. Can you maybe tell us what's your view on that and whether there's any genuine worry about that?
Yes, absolutely. So I think, as you said, it's a very valid concern. And a lot of the times patients will be concerned because they have heard of someone who, may have undergone a procedure and that didn't go well. But in general, endoscopy is very, very, very safe. And so, in terms of numbers, we say, for example, it's about 1 in 1,000 risk, right, to have potentially things like bleeding or perforation. But these things happen extremely rarely. And as Abdullah said, the thing is that you have to take into account the risks, but also the benefits. And endoscopy is extremely helpful in so many cases to help diagnose cancers, help diagnose conditions. So risks are actually extremely rare. And they're very well tolerated by our patients, endoscopies. So in general, patients, it takes about half an hour, maybe 40 minutes in case we're doing both an upper endoscopy and a colonoscopy even at the same time. So it's a relatively quick procedure. The patient doesn't feel anything since we're sedating most of the time, right? And so it's actually quite comfortable, and it's very, very safe.
Excellent. So part of your expertise, and we are lucky to have you, is inflammatory bowel disease. So within your patients with inflammatory bowel disease, and if you can maybe just briefly tell us what is inflammatory bowel disease, how can endoscopy help you in managing these patients?
Yeah, I think this is a great question. So inflammatory bowel disease is essentially an immune-mediated disease of our gut. So what happens is that patients that have IBD have an immune system that's in a way targeting their bowels and attacking their bowels, if we can call it that. And so that induces inflammation chronically in their bowels. And there are usually two types of IBD. We call this IBD, inflammatory bowel disease. Yes. So two types of IBD. There's Crohn's disease and ulcerative colitis. Ulcerative colitis only affects the colon, and Crohn's disease can affect really any part of the bowel, small bowel, large bowel, stomach, etc. And so it's really important in this case to make a difference between IBD, we'll call it IBD, as opposed to something else, right? So patients can have diarrhea, abdominal pain, and anything can cause these symptoms, right? Irritable bowel syndrome, which is a little, essentially some symptoms without any actual inflammation inside. It could be a lot of other diagnoses. It could be an infection, a bacterial infection, or inflammatory bowel disease. And so how do you really make the difference? It's really with the colonoscopy. And so Why does a colonoscopy help? Well, first of all, you can see live, essentially, the inflammation. We see it. We can see how severe it is. We can see where it is, and depending on where it is in the colon or in the small bowel, that gives us a lot of clues as to what's going on. And so you grade it, and on top of that, as you were mentioning, you're able to take biopsies. And so this is really the gold standard for establishing a diagnosis of IBD is I have my colonoscopy, I saw the inflammation, I took biopsies, the biopsies go to the pathologist, and the pathologist can confirm whether there is indeed chronic inflammation that is affecting these bowels.
Excellent, excellent. Can you tell us more about what kind of special IBD or inflammatory bowel disease services you have here at the Cleveland Clinic Abu Dhabi, and why would you recommend patients to come and see you and see your team here?
Absolutely. So we're very proud to have a really large and very specialized IBD program here. We have the largest program in the country. And I think what really made its success is the fact that we all work together. We have a very multidisciplinary team. I'm very, very lucky to have both of you as well part of the team. So not only do we have doctors specializing in IBD, we have nutritionists, we have our colorectal surgeons that are part of the team, and then we have other gastroenterologists like Dr. Abdullah and Dr. Ammar, yourself, that help us with other aspects of IBD. So unfortunately, sometimes IBD can lead to malnutrition, and so we're very lucky to have Dr. Abdullah to help us in that regard. And sometimes, unfortunately, over time, and IBD can also lead to changes in the colon that are precancerous and sometimes even cancer. And so sometimes what we ideally need to do is to use a different type of colonoscopy, which I'll ask you about, which is called the endoscopy. It's a special technique to really help us diagnose precancer really ahead of time. So we're very lucky to be able to have that service here. So, Dr. Ammar, do you want to tell us a little bit more about endoscopy?
Thank you. So the colonoscopy with endoscopy, as you mentioned, patients can have these changes that are precancerous, and patients with inflammatory bowel disease, whether it's Crohn's or ulcerative colitis, if it's uncontrolled, they can have 3 times higher risk for colon cancer than normal individuals. So it's very important that once they had the disease for about 8 years or so, that we start having regular surveillance for them so we can screen them for these dysplasia and these changes that we can detect using special dye and imaging technique. We call that image-enhanced endoscopy, whether we use it with dye or electronic imaging, and help us to do a very individualized screen and risk assessment for them. And if we find these areas, we could most of the time treat that by endoscopy also, which leads us to a different type of endoscopy, which is therapeutic endoscopy. And that can be a saver for them against colon cancer. Obviously, with endoscopy, there's a lot of other conditions, and it's part of how we diagnose things. So conditions like Barrett's esophagus, as you know, conditions of people with colonic polyposis or some of the genetic syndromes that have high risk for colon cancer or stomach cancer or esophageal cancer. We can actually do that by image-enhanced endoscopy and the use of endoscopy, which means just spraying a dye, and we have different dyes to do that. Now, I'll move back to you, Abdullah. So Sarah mentioned about the nutrition, and we are lucky to have you as a regional and international leader in the space of nutrition, which is a very complex topic. It addresses a lot of patients. But can you tell us more about your experience with nutrition? What sort of patients can you really help, and how endoscopy can help you, and what sort of nutritional devices or accessories you can use for these patients?
Thank you so much. This is a very important question. Nutrition, is an important field, and that kind of, affects different areas in medicine, not only gastroenterology, not only IBD patients or cancer patients. So typically, the patients that I receive can be grouped to different groups. The group of patients who have complex, severe surgical course and or complications. For example, patients who had bariatric surgery with the intention to lose weight, sometimes things unfortunately go wrong, either immediately after surgery or even months to years after surgery. They can have what do we call post-bariatric intestinal failure or malabsorption that would lead to malnutrition that requires, some form of intervention. The second group is the patients who had catastrophic medical complications. Unfortunately, we have a special group of patients who have thrombosis or blood clots that affects the blood vessel that lead to extensive surgery to the bowel, and then they end up having short bowel syndrome or short gut. The other group of patients is, unfortunately, a group of people who have gastrointestinal dysmotility that's severe enough to cause, inability to eat, inability to absorb and digest food. And the list actually go on. There are some chronic disorders. For example, inflammatory bowel disease patients can have severe malnutrition or different degrees of malnutrition. So regardless of the type of malnutrition, endoscopy definitely helps us reach a diagnosis in almost all the patients. Because to treat, you need, as we said, an accurate diagnosis, and oftentimes you need to do biopsies because a lot of these diseases are actually microscopic, that you have to confirm the presence of the disease or the presence of any other confounding diseases that can affect your course of management. Not only diagnosis, but Dr. Ammar and Dr. Sara, you may notice that endoscopy is also an important tool in introducing modalities of nutrition. So basically, I always tell my patients that there's only 3 ways to feed people. Number one is the patient eats by themselves, regardless of they're eating normal food or processed, supplements. The second type is using feeding tubes. Then the third is using intravenous nutrition, TPN, which is beyond the scope of our discussion today. So briefly, we can use the endoscopy to help us place feeding tubes. It can be either nasogastric or nasoenteric tubes. Basically, this is a tube that's introduced from the nose all the way down to the stomach or passing the stomach to the small bowel. Especially if you're not able to place these tubes by regular modalities such as, bedside or by radiology, then endoscopy is an important tool to introduce and to confirm the placement of these tubes that can be life-saving to patients. On a long term, you cannot keep tubes in patients' nose, right? So you have to consider alternatives, which is placing the tube in the stomach. We call them gastrostomy tube or percutaneous endoscopic gastrostomy or percutaneous endoscopy jejunostomy. It's either in the stomach or the small bowel. And one way to place these tubes is endoscopic. Of course, there's radiology and there's surgical, but endoscopy is probably the most commonly performed procedure to place these feeding tubes that can be used to deliver nutrition to patients who are in need for that type of treatment. I think, endoscopy is an important tool in the field of gastroenterology, regardless of what your specialty is. It's important for diagnosis and also for treatment. And maybe Dr. Ammar, you can tell us, you're the one who does most of the intervention and in treating, gastrointestinal, especially tumors, either cancerous or precancerous. Could you please elaborate more to the audience about the endoscopic treatment?
Thank you. So, as we've already discussed, Abdullah, about the importance of using endoscopic diagnostic tools, whether it's electronic with technological imaging, especially now that we have, I think we are really proud in gastroenterology in the field of endoscopic diagnosis that we, one of the first fields in medicine to utilize artificial intelligence, and that we are doing that on daily basis at Cleveland Clinic Abu Dhabi in all our endoscopic procedures, especially in colonoscopy, to be able to help us detect subtle abnormalities, polyps, and be able to reach a very accurate diagnosis for every patient that we see. In terms of the other diagnostic tools that you asked me about, as we mentioned in the upper GI tract, we do a wide range of endoscopic imaging techniques for very different conditions, not only for cancer conditions, but also for other conditions like, for example, in this people with difficulty in swallowing, who have a rare condition called achalasia, where they have a problem with the swallowing and the lower esophageal sphincter is very tight and they cannot swallow. We do have different diagnostic tools that we can put through the endoscopy, like the Bravo capsule, we call it, and that can help us in diagnosing these conditions, and then we can offer patients very effective, minimally invasive treatment. So that's kind of one example of how endoscopy can help us. Excellent. So I think with that, I would thank you both, Dr. Sara,
Thank you.
Dr. Abdullah,
Thank
for
you.
your wonderful contribution.
Thank you.
And thank you again for listening and tuning in, and we'll see you in the next episode.